Good morning, everyone. Thanks for joining us. Sorry for the delay this morning. We had a minor technical difficulty, but we should be good to go now. So I appreciate all of your patience and thank you for joining with us and sticking with us this morning. So today's Knockout Opioid Abuse Day webinar is opioids in pregnancy and neonatal abstinence syndrome. Today's webinar is designated for one AMA PRA Category 1 credit, one ANCC contact hour, one ACPE contact hour, one AAPA Category 1 CME credit, and one ADA CERP continuing education credit by the American Academy of CME Inc. And for any pharmacists who are claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. This webinar has been approved by NJOEMS for one EMT elective CEU, and the Partnership for Drug-Free New Jersey is approved by the Board of Certification, Inc. to provide continuing education to athletic trainers, and this program is eligible for one Category A CEU or hour. PA Planner Dean Barone discloses that he serves on the speakers bureaus of Ethicon and Johnson & Johnson, and all other planners, faculty, and reviewers have no relevant financial relationships to disclose, and all relevant financial relationships have been mitigated. If you wish to claim CME or continuing education credit, you must do so within 30 days from today's date. After that date, we will no longer be able to issue you credit, and we'll provide that information at the end of today's webinar. Today's webinar is jointly provided by the Partnership for Drug-Free New Jersey and the American Academy of CME Inc. and is being held in collaboration with NJ Cares, the Office of Alternative and Community Responses, and the New Jersey Office of the Attorney General, as well as the Opioid Education Foundation of America. And I thank them all for their support and partnership and collaboration on not just today's learning activity, but throughout this year-long learning series. And so I'm so pleased to welcome today's expert faculty. Dr. Salma Ali is an associate professor of pediatrics at Rutgers, New Jersey Medical School and a neonatologist at University Hospital in Newark. She comes extremely highly recommended. She spoke at an event that I held back in 2015 and was very well received. And so we're really, Dr. Ali, looking forward to your presentation today and appreciate you joining us to share your expert information. So I will turn the presentation over to you. There you go.
Okay.
Perfect.
Okay.
Thank you.
So today's talk is to discuss the impact of opioid abuse epidemic on pregnant population in USA. To discuss what is NAS, NAS and NOW, NOS are just interchangeable. I'm just going to use NAS for simplicity's sake. It's epidemiology, demographic pathophysiology, clinical presentation, and diagnosis. Pharmacologic and non-pharmacologic therapy for NAS, the program that we develop at Rutgers and JMS, UHNJ, and then the follow-up outcome of these newborns. I don't have any financial disclosures.
Thank you. Dr. Ali, just before you continue, everything looks beautiful. If you could just get a little closer to your microphone, we're getting some feedback that you're a little muffled.
Okay.
Yes,
Sure.
thank you.
All right. So, okay. So opioid abuse and dependence in pregnant women has been on the rise. So in this slide, you will see an overall rate is around 3.5 per thousand, but it is higher, much higher in a population between 20 to 34 years of age, which is a fertile population, the pregnancy population. So in that age group, the opioid abuse is much higher. So the drug-related overdose death among women has also been on the rise from 2000 to 2010. And the most common cause of that death is, say, opioid, okay? And the rest of them are really way below. So it is on the rise, use, and also related overdose death. So, but this increase is very disproportionately higher in rural area as compared to the urban areas. Okay, so rural areas outnumber it much more than we used to think that inner city urban area is the place where it is high, but it has gotten up in the suburbia and the urban area. So if you look at the prescription of opioid to women of reproductive age by insurance, around 30%, 27% are private, and another 40% are Medicaid insured. So this is an insured population, who are who can be reached and treated and put into a program. So this is a CDC slide so it shows that around 7% of the women actually did self-reported using the opioid during pregnancy. Among those 7%, 30% of them said that they were never being counseled by a healthcare provider about the potential effect of prescription opioid used by the baby. And 1 in 5 reported misusing that prescription opioid, either getting it from other sources or using it for a reason not related to pain. And then another 27% actually said that they wanted to cut it down or be enrolled in a program if they were offered. Okay. So there is a willingness there. Okay. The impact of substance abuse, maternal use affect both the mother and the baby. And we are going to go into detail on these. So the maternal complications, okay. These moms generally have low or prenatal or no prenatal care. They tend to deliver preterm babies, especially with cocaine and stimulants. The cocaine also is related with a significant high risk of abortion. There is an increased death of prenatal and intrapartum death. They can have abruptio placentae. They can have prolonged and premature rupture of membrane. Breech presentation is common with heroin abuse. These mothers can also have a much higher need for intrapartum analgesia because of the tolerance to these drugs. These moms can have a very high risk behavior. The drug-seeking behavior can put them into at risk of having multiple sexually transmitted infections. These sexually transmitted infection can cause like pelvic inflammatory disease and put them at a risk of ectopic pregnancy. These mothers are generally very malnourished, and that leads to intrauterine growth retardation for the fetus. There is always like a psychiatric comorbidity. So if the mom is giving a history of drug abuse, they should always be screened for mental health issues, and vice versa. Mom can have higher incidence of pregnancy-induced hypertension, and they tend to have a higher incidence of delivery outside the healthcare system, like at home and on their way to the emergency room. In the emergency room, they are at risk of uterine rupture because of strong contraction, especially with cocaine. They can have systemic complication in terms of arrhythmia, seizures, sudden death, multi-organ failure, hypertension, ischemic visceral damage. So now we are going to go into neonatal complications. Okay, they are at risk of babies of getting delivered prematurely. They can have perinatal depression if the mom is on high dose of opioids, heroin, fentanyl. And these babies should not be given Narcan or naloxone intrapartum because that can precipitate acute withdrawal and seizures. These babies tend to be lighter for weight, growth retarded. They are at risk of acquiring multiple infections also. Like, recently there is a many-fold increase in syphilis and HIV in the mom, and then the hepatitis B, hep C, etc. And this can also affect the babies. They can have ischemic organ damage from like vasospasm. They can have hypertension, same mechanism like mom, arrhythmia, seizures if are not treated, increased risk for SIDS. We will discuss that a little bit more in detail. They generally have a very poor state control, like self-control, self-pacifying, self-soothing behavior is not there, and that itself put them at a risk for further future abuse and neglect. And then one of the major complications of this intrauterine drug opioid exposure is neonatal abstinence syndrome that we are going to discuss it in detail today. So neonatal abstinence syndromes are signs and symptoms in the newborn that results from sudden discontinuation of fetal exposure of substance that were used or abused by the mother during pregnancy. These substances can be legal or illegal. So what are these substances? Most commonly attributed to the exposure to the opioid are pain relievers, prescription ones, Vicodin, Oxycontin, Percocet, and the illegal ones like heroin and now fentanyl is like way high. So these mothers can also NAS can be associated in moms who are in a opioid maintenance program, either methadone or buprenorphine. So some cocaine, amphetamine, barbiturates, etc., have been implicated, but main culprit is opioids in causing NAS. Okay, so this the numbers are increasing. Number of infants with NAS are increasing. In year 2000, there were around 3,000 babies reported. In the year 2012, around 21,000 babies were reported. Okay, in year 2012, one baby was born every 25 minutes with NAS. In 2019, from CDC thing, one baby was born with NAS every 15 minutes. Okay, and I think this is just the tip of the iceberg. The number is actually much higher. It's just the poor reporting and poor way to catching these babies. That's why we are seeing such a low estimate. So newborn victim of opioid epidemic. So again, this bar graph just tells you that they are just on the rise, and there are some complication related to that. Okay, now if you look at a country-wise distribution, the darker the blue is, the higher is the number of NAS per thousand hospitalization. So East Coast has its fair share. So New Jersey, Vermont, Delaware, Massachusetts, Connecticut, Rhode Island, Maryland, they are all ranging somewhere between 7.7 to more than 12.8. Okay, so we do have a higher rate of NAS babies in United States. So now we are going to look at our New Jersey data. So this is from New Jersey Department of Health website, and it shows over the year the number has been increasing. But the more interesting thing in this data is that the number has gone. We already have inner city like Essex County, Newark, and all that. I worked my entire life in Newark. In these programs, the numbers are always very stable and they remain the same. It is the suburbia, like the South Jersey, Cape May, Cumberland, etc., where the numbers has gone higher, and the Sussex, Warren County, where the numbers are just way high. Okay, they are like even like more than like Cape May, more than 25 per thousand kind of number we are talking about, as opposed to like what we see in Newark and all that, where we have like 7 to 8 per thousand deliveries. So suburbia is the one that is affected mostly by the opioid epidemic, and the mothers are also, who are living in that suburbia are the ones who are getting affected. If you go by ethnicity, okay, so this pie here, you will see that, the white pregnant female make around like 75% of the pie, okay? So rest of them Hispanic, other black, and other minorities, okay? So now, the demographic has changed remarkably, and we should have changed our also approach in teaching, in approaching these mothers who live in suburbia and who might have insurance and all that, because this is the top population which is having actually maybe a reverse discrimination in the sense that they are not being identified, and that's the way we identify our inner city minority population, and they might just not be getting the treatment and the support they needed. Okay, if you go by the insurance, you will see that this is Medicaid and this is private insurance, and the orange one is like other insurances, and only the top very small percent, less than 5% out of that 100% is uninsured. Okay, so the good news is that they have some kind of insurance and they can be treated. If the cost should not be a problem, cost of treatment should not be a problem. The problem is mainly in terms of identifying these mothers and the babies, especially the babies, because even in the New Jersey Department of Health, this site, they put down that the identification of these NAS babies is extremely difficult because the bottom paragraph because there is no ICD code for NAS itself. Okay, so in other words, what we have, just because we don't have any ICD code, okay, for NAS, when we are doing chart review, okay, it's like insurance company comes in and they look at the protocol and they say, well, this hospital did very well using the protocol. Okay, let's just look at it, how they are doing. Well, there is no ICD code for NAS. Okay, the only code that can use is P96.1, which is neonatal withdrawal symptom from maternal use of drug addiction. Okay, so the fact that we are not identifying these because we are not even properly uh, uh, having diagnosing them with a code. So what is NAS? So it's a withdrawal syndrome that occurs primarily among opioid exposed infants shortly after birth. These symptoms occur somewhere between 48 to 72 hours after birth, and it also depends upon the appearance of symptoms occurs upon whether it's a short-acting medication or a long-acting medication, and when was the last time mom got that drug or medication. Okay, if the mom has not taken that drug for 3-4 days, which is kind of unusual, the baby will be withdrawing right at birth. Okay, but if the mom has the last dose right intrapartum, then baby may have like 2 to 5 to 7 days to withdraw, depending upon how short acting or long acting medication that she's on. So how does the mechanism of drug withdrawal? Okay, so how does it works in utero? Okay, see, can easily cross the placenta. Placental permeability increases with gestation and polysubstance abuse. Opiate has prolonged half-life in fetus. This fetus metabolize this in the liver and kidney, pee out in the urine, and then swallow again. So just keep on bathing into these drugs, okay, throughout the gestation. Opiate can easily cross the fetal blood-brain barrier, okay, so that it can go directly into the baby's brain. Placenta is more permeable to synthetic than semi-synthetic opiates, and the pathophysiology of opiate withdrawal is more complex in neonates because of immature neurologic development, impaired neurologic processing, and complex maternal-fetal and placental pharmacokinetics. Okay, so there is a placenta involved also, so it just makes it a little bit more complicated. So when we look into the premature babies, the mechanism of withdrawal is, so the preterm babies generally have lower incidence of NAS and the severity of the withdrawal is also less. So this may be because of a shorter gestation, decreased cumulative exposure because of shorter gestation. It could be due to decreased transmission because of low placental permeability, which increases with increasing gestation. It could be because the morphine clearance and excretion is low because the premature babies have immature kidney and the liver. And they also have less fatty tissue, so methadone and cannabis, it get accumulated in the fatty tissue, so they don't have less stores. They also have decreased receptor development and decreased receptor sensitivities. They are immature, so the neurotransmitter receptors are not well developed to respond. In a way, the full-term babies respond to drug withdrawal. Okay, so the neuroreceptors that are involved in our withdrawal syndrome are through a cascade of events. Okay, like there is an increase in corticotrophins, which can cause increased stress, hyperphagia, decreased dopamine, which is like a happy juice and which is not there. So they are very irritable, they are very anxious. Acetylcholine is increased, so they can have like autonomic symptoms, vomiting, diarrhea, yawning, sneezing. The serotonin is low, so they have a sleep disturbance, fragmented and less sleep. And then noradrenaline is high, so they can have hyperthermia, hypertension, tremor, tachycardia. So all those things in disturbance in the neurotransmitter uh, can result in a cascade of symptoms leading to NS. So what is the onset, frequency, duration, and frequency of NAS by different drugs or substances? So among opioid, so heroin being the shortest acting, onset starts around 24 to 48 hours. It is quite frequent, depending which study you are looking at, somewhere 40 to 80%, and the duration of the NAS lasts 8 to 10 days. Methadone, on the other hand, is a longer acting drug. So onset happens somewhere between second to third day, and maybe it may take as long as 5 to 7 days. For methadone babies, we keep them at least minimum of 5 days to look for withdrawal symptoms. And then the frequency is again highly variable, but it is pretty common, and it lasts for more than 30 days. So generally much longer. Okay. So the methadone withdrawal severity is actually, or even frequency, is not related to the mother's dose that much. There's not much correlation, or the duration, or the plus or the cord level. Okay, they looked at the cord level of methadone, and the correlation was not there. Buprenorphine is somewhere between the heroin and methadone, so onset occurs between second and third day. The frequency is in between, also less withdrawal than methadone, and it's a shorter withdrawal too. So among three of them, depending upon the duration of action, the withdrawal onset and duration can vary. Okay, so so how do we identify these babies or the mom who are using drugs? Okay, so so um, so the Academy of OBGYN and Academy of ASAM has endorsed that early universal screening should be done in every pregnant woman for the history of taking any drugs. Okay, so they recommended some validated screening tools, which are 4P, NIDA, Quick Screen, Craft, etc. Some of them. So in this is a verbal screening. You ask the mother some questions and then they responded. So it is very unreliable because it depends on the caregiver and the patient's confidence and interaction, how much they trust you, how much they can tell you about these things. So self-reporting itself is not very reliable. So this study has shown that they looked at a certain number of participants, and they checked 5 of these screening instruments that has been commonly used by OB to see how reliable they are. They find out some instruments were good for more specific, some were more sensitive, and some were good for area under the curve. Okay, but none of them, the bottom line, last line, none of them showed both high sensitivity and high specificity and area under the curve. Okay, for all of these measures. Okay, so in other words, not a single screening tool is good enough, specific or sensitive enough to identify these moms. Okay, so again, so maternal self-reporting based on these screening tools are very unreliable. And that goes along with some Canadian studies which look into the neonatal, the mom who said they never use drugs. 27% of these babies' urine were positive for drugs, and another 24% of these babies were positive for meconium were positive. So that just emphasizes the unreliability of screening tool for drug abuse. So what next? Okay, so can we do the testing, toxicological testing? Okay, in our hospital, we do targeted toxicological testing. So targeted toxicology is a criteria base. Okay, if there is a high risk criteria, we do the toxicological testing on the mom and the baby. On these criteria, we don't have that gravida 4, but like no or late prenatal care, previous foster a child, and then CPS involvement, abrupt show, physical sign of domestic chronic pain, multiple STDs, risky behavior, mom coming intoxicated, these needle signs and all that. So those are the criteria, and teenage mom also we screen them too. So those are the criteria we screen the urine and the meconium for these babies. Okay. So, I mean, this we develop these criteria because we don't want to just say that, well, we don't like the way this mom look or this, and I want to test her. So you just have to have, like, from ethical and legal point of view, some kind of criteria to justify why you are testing. If it is up to me, and I will discuss it in advocacy, I suggest it should be a universal toxicological screening on the mother and the babies because we are really missing a lot. Okay. So how do we screen? Okay, so neonatal screen, we do the urine at our place also. It detect only the downside is that it only detect the recent exposure. Okay, if the mom has taken it a week before, and then you might not catch it in the urine. The meconium is actually very good metrics for detecting intrauterine drug exposure. It's as early as 14 to 16 week actually. Okay, and but it may not be available if baby has already passed stool in uterus or has imperforate anus or delayed passage like in premature babies. Sometimes they take a week to pass it. So we also tested at our hospital. We did a study on umbilical cord tissue and we compared the umbilical cord tissue. It is published in Journal of Perinatology, and we compared it with meconium drug screening, and it is a mass spectrometry, extremely reliable. Okay, so correlation was extremely good. The benefit of umbilical tissue is right then and there. Okay, you don't have to wait for the baby to pass a stool and all that, and you don't have to worry about the other conditions where you might not be able to get it. So it is a reliable test and is commercially available. Okay, then we also this we can also do the neonatal hair. Okay, the drug is present in the baby's hair from 6 months onwards of the gestation, and we can use it for the first 3 months of life also. It is going to be reliable. So these are the different panels that are available. We use the 12 panel, which pretty much cover a lot of drugs. That's the maximum one that is available. And in addition to that, we also use the alcohol exposure. So FAEE, because a lot of, I think in my, that, alcohol actually is the number one preventable cause for mental retardation in United States is the legal drug. And what happened is that if we have this test showing that this baby has alcohol exposure and down the road baby is not doing well in school and all that, that history and the test can prevent $1 million workup for whatever autism, poor behavior, ADHD, etc. Okay, so you can just, so that is an additional service we do at our hospital. We look for the alcohol screening also, and we follow these babies, all these drug exposed babies, we follow them in our high risk clinic, including the alcohol exposed baby. So what are the signs of drug withdrawal? Okay, so, this GI-wise hyperphagia, vomiting, loose stool, they can have seizures untreated, they can have respiratory symptoms, abrasion, excoriation, sweating, fever, mottling, yawning, etc. And these signs can occur somewhere between day 1 to day 7 of life. And we are going to discuss a little bit of this implication also later, okay? So how do you assess the severity of drug withdrawal? So we use Finnegan, modified Finnegan, which is 21 symptoms, and any score that is more than 8 means that baby is having significant withdrawal. There are other scales available also, which has been validated and used in some research setting also. But Finnegan is like the most commonly used, like majority of these the NICUs and places use the Finnegan scores. So now we have another one, the Eat, Sleep, and Console. So the original Finnegan is around 32 item and modified is 21. So they modified it so they will to minimize the handling of these babies as compared to the original one. The Finnegan mostly focuses on the symptom severity. Okay, so what happens that if baby is like having like a neurologic symptom, okay, mild tremor, okay, versus myoclonic jerk versus seizure. So severity of the symptom can very easily be assessed, titrated, and control by titrating the medication. Okay, so that's the beauty of Finnegan, that you can titrate and control the severity by titrating the medication dose. Eat, sleep, and console, on the other hand, focuses on infant's function. In other words, ability to eat, ability to sleep, and ability to be consoled. Okay, and it stresses on maximizing non-pharmacological therapy. So the Eat, Sleep, and Console is the tool guided by infants' clinical signs of withdrawal through eating more than 1 ounce or breastfeeding, sleeping more than 1 hour undisturbed, and console more than 10 minutes. If these criteria are not met, they start into non-pharmacological and then pharmacological therapy. So it is simple to use, but it also depends on our NICU setting with private pediatric floor. It's generally used in a pediatric floor, a private room with a presence of a caregiver, because the caregiver involvement is very important with this group. Okay, like cuddling and rocking and all that. So if it is like a open unit, like our neonatal ICU, it could be a problem, because we cannot provide a quite one private room with parents. Some of our parents are not even available. They are like incarcerated or in a rehab program. So it is available. It's very good from non-pharmacological. And so which tool is the right tool? Okay, there is not necessarily a right tool. Okay, the key is consistent use and standard education of the tool. Okay, you have to be comfortable and be consistently using it to be good at it. Okay, the use of non-pharmacological bundle along with NAS tool is very essential. Okay, before going to pharmacological therapy, you have to provide non-pharmacological bundle, and there should be a correlation with patient data exam and scoring trends. Okay, so they should all be correlating. One should be supplementing the other. So how do you manage NAS? So our goal for management is to treat with drug from the same class of exposure, to minimize symptom, to promote appropriate growth and weight gain, and to promote caretaker-child interaction. The concern with pharmacotherapy especially is that a prolonged and multiple therapeutic exposure and therapeutic sedation. Okay, the optimal regime is not yet established. Okay, this is due to the considerable heterogeneity in diagnosis and the treatment. The only clearly defined benefit of the pharmacological treatment is short-term amelioration of signs, clinical signs, which is important if untreated. Like in days before Finnegan came up with this thing, babies have significant morbidity and mortality. As much as 30% ended up dying from these untreated signs and symptoms. So even acute short-term amelioration of clinical sign is important. It is unknown if the long-term morbidity is changed by pharmacotherapy. Okay, so we really don't have much to in terms of whether it changed the big picture. So these are the medications used percentage of infants. Okay, this survey over the years showed that morphine was the drug of choice all along. Okay, with the recently phenobarb use has gone down significantly. There is a background user of methadone, around 10 to 20%, who generally use methadone in a situation where the benefit of methadone is like a once a day or twice a day dosing versus morphine is every 3 to 4 hours. So the benzo has been like not really much, and clonidine is also was a good idea, but really did not get caught up with the treatment. So most, favorable treatment is around 70-80% is like of the patient, babies being treated with morphine. So then, this study is an interesting study. It was done in New England Journal of Medicine, where they compared buprenorphine with morphine and showed that buprenorphine actually was able to decrease the shorter length of treatment when it compared to morphine, okay, which was significant. And the same way, buprenorphine was compared with methadone, and it also showed that there was a shorter length of treatment with buprenorphine as compared to methadone. So why don't we use it? Okay, so the reason why, so when these studies came out in 2017, 18, I got very excited. I got to the pharmacy and said, well, why don't we use this? So the problem is that it is sublingual, which is not a big problem, but it has a very high concentration of alcohol. Okay, so that is why buprenorphine could not be used in neonatal population. And we talked to the pharmacists and asked them, can we just have an alcohol-free preparation? They said that, I mean, it is possible, but the shelf life is not going to be very stable. Okay, so if we use go in that direction, so the idea sort of did not cut up because of the preparation had alcohol. Okay, so regardless to what drug we choose for the treatment, the presence of a treatment protocol actually is an stringent weaning guideline. Is a very good way. It has been shown that it can decrease the length of treatment in babies with NAS. Okay, so treatment and cost. Okay, the infants who require pharmacological treatment, either with morphine, methadone, and in those days they were Finova. So 30, 68, and 91% of these infants required pharmacological treatment in different studies. Okay, so like 1/3 to 2/3. Average length of stay was around 23 days. Mean hospitalization cost was like 9,400. And total cost per year was 1.5 billion. Okay. Out of this, 1.2 billion was paid by Medicaid. I mean, these are significant numbers. Okay. And now when you look at NAS admission, 50% of NICU admission in some hospitals of admissions are related to NAS. And in the same hospital, there is a significant inter and intra-hospital variation in the treatment and outcome of NAS, like a provider variation and then inter-hospital variation itself. So recent studies showed that the quality improvement collaborative in 199 hospital, they showed that uh, only 40, less than half has a policy for standardized scoring. Less than half has a policy of breastfeeding on substance exposed newborn, and 60% have something written for NAS treatment, pharmacological treatment. So there is not only just like, which drug we should use, it's also very important how to use it. So there were different collaborators who showed that having a standardized protocol can result in significant decrease in like Ohio Collaborative or Mount Oxford Collaborative can decrease in the length of treatment. So what we did was, this was our study at University Hospital. So around the time when I wrote that IRB approved protocol, we had a big inter-provider variability. We have different attendings from different programs, and they did whatever they did at that place. So our length of treatment was actually creeping up and up, and being there for many, many years before them. I was noticing this increase. So we developed this NASTOP program for NAS babies. Okay, so these are the non-pharmacological thing, and it was presented in Hot Topics in Neonatology, which is the largest neonatologist international conference. It happens every year, and this was one of the 14 abstract that was accepted. What we did was, by the implementing of this NASTOP treatment protocol, we were able to um, decrease the length of stay. So what was this protocol? I mean, this study actually was that by using a standardized NASTOP protocol, you can decrease the length of stay, the hospital resource utilization, and the cost and consistency between the providers. So we did the non-pharmacological approach. It is kind of hybrid protocol between eat, sleep, and console. And the the pharmacological part is what we develop. So in our unit, because our unit is not like a private room setting, it is one big unit, and the rooming in and the sleeping in by the parents are not available. So we were just optimizing it to the best, uh, without having the private room setting. So that's why we could not call this Eat, Sleep, and Console, because that was not this setup. It is an inner city hospital. So our pharmacological treatment was divided into different phases: initiation, escalation, weaning, and discharge. So we provide all the criteria how to go up and down. And then this was our result. Okay, so pre-protocol length of treatment was around 36 days, and post-protocol we drop it down to 10 days. Okay, so length of yeah, 36 to 10 days. Okay, p-value of 0.03. Length of stay is a little longer because of the social hold, but we also showed that there was a big difference. So use of protocol definitely help. Okay, it just, so we went through a big thing, like we educated everybody. If there was like a social worker, pharmacy, the residents, nurses, us APNs and attending, everybody, got the information, they were educated, and then we got into this. So implementing this standardized protocol significantly reduce the mean length of stay pharmacological treatment. It also reduces the variation between the provider in their management of NAS. Non-pharmacological approach was used with for everybody, and the main gain was in the area when we escalated. We lost a lot of days in those 36 days of treatment before the protocol. We were mainly losing our days in escalation, backslide, and weaning phase. Okay. So babies were started and then left for the next round, next weekend, next Monday, and they sat there for days. Okay. So that at least help us provide the criteria for all these condition situation, and also provided the criteria for the initiation of adjunct therapy as phenobarb. Okay, phenobarb was quite widely used before the initiation of this protocol in our unit as a co-therapy. But what happened is that with the use of this protocol, we did it and decrease it to significant number, and we did multiple cycles, and we showed that lately, for last several couple of years, maybe phenobarb use is down to zero. Okay, so it has, if you it so it is saying that if you use a protocol and use it properly, and adjust the need for escalation or backslide, or weaning properly, there is no need for adjunct therapy. Morphine itself can control the signs and symptoms of drug withdrawal. This protocol, the nurses love it. I should have done a survey. Okay, they said that it just give them. It's not the attending, coming in and saying what to do that day. Nurses will look at the protocol and look at the dose and all that, and they will say, "Oh, baby is closing to the like discontinuing dose, mommy, get ready," or baby is backsliding, mommy. We just have to work with the baby. So that protocol empowered the nurses also in discussing the management with the physician, and also with the family. So conclusion is that the standardized locally adapted NAS protocol, such as NASTEP, can reduce the duration of hospitalization. We did a pragmatic adaptation because our of Eat, Sleep, and Console, and our protocol because we have an open unit, and we showed that the phenobarb use has been gone to zero. Okay. So in conclusion, drug NAS and is on the rise. 50% of NICU hospitals are occupied by these babies. This is the cost, and lack of protocol can cause issues in long run. And the other thing is that this is what I wanted to emphasize a little bit. That's why I put it in red. Happen between days of life, and if the baby is not identified, and most of them will not be identified if we don't have like a positive screening, or we have a high risk criteria, or will go home. Okay, and they will come to the emergency room, which I've seen many, many times, with fever, seizures, dehydration, SIDS, expensive, then vomiting, diarrhea, and they get like a very expensive workup. Fever in first few days is like a qualify for a LP. Seizure will be for CT, MRI. if they have been identified properly in well baby, and pediatrician or the ED provider will know that this could be the cause for the baby's symptoms. So they a lot to and suburban insured females. So we were able to do that, and we can share it to, our experience to our goal. Okay, and this is where the and in management of these infants, and of course mothers. If we identify mother, then we can identify these babies. So standardization of toxicology screening criteria for both mom and the baby. Okay, so in other words, should we just do a universal screening for every pregnant woman to toxicological to see if they are using? I mean, we did it for HIV when the HIV was a big stigma. And New York is the state who just started testing all these babies. Every single baby got tested for HIV, and then we got the disease under control. So but with the stigma, with the drug abuse here, people shy away from advocating for universal toxicological screening of every pregnant woman with the idea not to stigmatize or punish, but to help provide care and support for both mom and the baby. Okay, so we need a standardized protocol for breastfeeding, rooming in, non-pharmacological, which we all have it. So, okay.
So, Dr. Ali, I think we're coming to the end of our time here. We have um, we
Okay.
have about
Let
another
me just
minute.
give you one more slide and
Yes,
then I will
please go
stop.
ahead.
Okay. So the outcome wise, okay. So there is outcome wise, okay. So okay, what is going on here? Okay, I think the survey is already there, so I don't know how to take this. Okay, let me just take it off. Okay, I will stop here. It's okay. And then we can just talk
Yeah,
about
no,
the.
I'll stop here and I know you gave a lot of information. We had quite a few questions. I know one in particular, what mitigations might be used to protect the fetus from a substance using mother. I don't know if you can jump in on that quickly and maybe
Okay,
address if like non-opioid pain medicines or alternatives that might work.
okay. I mean, the main thing is that we should first of all we need to identify these moms, okay, to see what if they are using drugs, okay. Then we should put them into the programs, okay, like the Academy of OBGYN and the Academy of the Addiction Medicine are saying. So our goal should be just to identify them. Okay, the problem is that, okay, I talk to my OB, even my struggle with my OB. Okay, I say, well, I mean, screening is very unreliable, based on those questionnaire. So what else can we do? Okay, this is the major disconnect. Okay, the missing link is that if we just go by screening, which the OBGYN says that, oh, okay, yeah, we 100% screen our mom, anybody, pregnant woman who come to the clinic get screened by this thing by a random person, most probably, or somebody that our mothers, especially in the drug abusing population, they are very suspicious. Okay, they will not trust you unless they really have a long-term relationship with you. So these moms we are missing a lot of them. Okay, so what I suggest is just universally screen everybody. I maybe just send toxicology on umbilical cord or something. Just identify them, like the New York State did for HIV. They just say send a cord blood sample in 80s, and we were able to bring the HIV rate, perinatal transmission rate, to near zero, okay, by having that kind of advocacy, okay. So this is what we need in in our setup. So keeping it out like a stigma. Everybody get tested. Every pregnant mother get tested. Every baby get tested. So there's no stigma. Okay, like we said,
Sure,
test
yeah.
for GBS or we test for diabetes. We test for this. Okay, testing is very important. Not a screening, questionnaire. So once we get this, okay, we will be able to provide proper. At least we will work for providing. We have very few programs. Okay, like maybe 1 in 11 has been satisfied for pregnant women program for drug addiction treatment and all that. But at least then we will go to the state and we will say, listen, these are our numbers. CDC did, like, I think 1922, 6 states, they said mandatory mandatory reporting of these NAS babies, okay, and Kentucky and some other states, okay. And then they have a good idea that how many babies are actually there, how many mothers are there, then they can allocate funding for those
Exactly. It seems
programs.
that the more information, the more that we have, whether through testing or research, the better situation everyone will be in, and including the reduction of stigma surrounding the issue. So I think
Yeah.
that's a very
Yeah.
significant point. I know we
So
have a lot of people on from various backgrounds. And I think that's universal for everyone. Everyone can play a part in helping to reduce that stigma by sharing that information as practitioners to advocate for that overall testing and within the community to
I mean,
help
really,
reduce
the
that stigma.
universal toxicological testing is the only way to go, okay?
Yeah,
And without having any stigma. If we are gonna shy away from it, and I mean, OB really a lot of time are not buying into it because they don't want to upset the patients. But if you tell the patient we are screening it just like we screen you for for diabetes, okay, then it is no big deal.
exactly. It's no
The
big deal.
buying in is going to be there.
Yeah,
We are just like, for last 15 years, okay, I have been asking and trying to advocate for universal toxicological screening, okay, on the mom and the baby. I mean, if we get that under control, we will know the exact number. We will be able to provide the program for the mother and the baby.
yeah.
So if you
Well,
can take one thing out of this presentation,
yes.
that is the
And
the
that's the point to take.
yeah,
So
point.
important. All of the information you shared today was so important. I want to thank you so much for your time and sharing your expertise with us. I want to thank all of you who are with us today. I know we got a little bit of a late start and we're ending about a minute or so late. So I want to thank you all for sticking with us. Information is on the screen.